Prostate cancer. What are some of the questions that occur in prostate cancer in the year 2021? This is Dr. Robert Miller, and this is one of several videos on the subject. So do we know who gets prostate cancer and why? Is it worth screening for this cancer, and why is that so controversial? And finally, is the PSA blood test really the best way to protect yourself from ever dying of prostate cancer? Here's a schematic of prostate. It doesn't really look like that. There's usually no large lump in the prostate. Most people with prostate cancer have scattered cells throughout the gland and basically no symptoms. If you have a weak urinary stream, it's almost always due to benign enlargement of the gland, so-called BPH, putting pressure on the urethra or the bladder. So since most people with prostate cancer do not have symptoms, it'd be necessary to screen if you were trying to diagnose this cancer early. So where does the controversy come in? Well, number one, it's because it's such a common cancer, but many cases are so indolent or benign, they should not be treated if discovered. So maybe we shouldn't even look for them. Number two, the PSA test does not perfectly predict the men who need a biopsy. So we could be over-diagnosing this cancer. There are now better tests to use rather than a PSA to predict the biopsy, and I'll cover that in this video. And then number three, the path report may not perfectly predict who actually needs aggressive treatment, so we could be over-treating. There are now better tests, usually genomic or genetic tests, to predict who needs treatment, and I'll cover that in the next video. So the topics to consider here, the general statistics, how common, how serious. Number two, do we know enough about what causes the cancer that we can just prevent it? Number three, screening, do we really benefit from diagnosing this cancer early? And then four, if you are diagnosed, what are your treatment options and how would you select those? We'll cover that in the next video. So number one, prostate is still the most common cancer in men. It makes up 26% of the cases. It's the second most lethal cancer in men, 11% of the deaths, 34,000 predicted in 2021. If you look at the top four cancers, prostate is second only to breast as frequent, 248,000 cases. Is less lethal than the other common major cancers, 34,000 deaths as noted, but still 5.6% of all cancer deaths. And because it's less lethal, the 5-year survival for patients is 97%, which makes it very difficult to use 5-year survival stats when you're trying to compare different treatments. No matter how you treat the patient, whether you do surgery or radiation, at the end of 5 years, almost everybody is still alive. In fact, most patients present with early stages, 85%, it's either local or regional. And again, the 5-year survival with this group is close to 100%. And even the worst situation, only 6% of people present where it's already metastasized, usually to the bone. And even in this group, which is the worst possible group, at the end of 5 years, nearly 40% of the people are still alive. So very favorable. If you compare this with, say, lung cancer on the left, you can see 6% of people will eventually get lung cancer. 4.5% will die of lung cancer and is following closely right on the heels of this. Whereas prostate cancer, 12.5% of men may get prostate cancer. You can see here in red, but the death rate is much, much lower, 2% and change. And there's a large gap between these two. And if you look at probability of ever developing invasive cancer, prostate is 12.1%. Interestingly, look at the age here. Most of these cases, 8.7%, don't even show up until you're over 70. So 72% of the cases are diagnosed in men over 70, and ironically, 70 is the age they tell you to stop screening. So that doesn't seem to make much sense now, does it? And again, you can see here in red is the graph on when you diagnose this starts to take off in the 50s and 60s. But most of these cancers show up in their 70s, whereas the death rate from this cancer is much later in the 80s and 90s, so a long gap. And so it makes sense when you think about treating this disease to consider the man's life expectancy when you try to decide whether treatment is really necessary or worthwhile. In fact, an old common saying was more people die with it than of it. Now, where did that come from? Well, if you look at autopsy studies where people die of old age or whatever cause, and you do an autopsy and have them to look in their prostate, in older men, 70 to 80% of the time, there may be some occult or hidden prostate cancer cells in there. So if you did an autopsy on 100 old men who died randomly, only 2 of them would have died from prostate. 12% would have been diagnosed sometime in their lifetime of being told they had prostate. But as many as 70 had occult cancer found in their prostate. So again, 70 or 80 people had cancer, and only 2 of them, their death was due to the cancer. So more people die with it than of it. And so you go back to the PSA test. It was approved in 1986. And you can see the diagnosis of prostate just skyrocketed, reached its peak in 1992. The PSA probably picked up 5 or 10 years worth of cancer. And then the numbers went down. And in fact, the US Public Health Department opposed PSA screening in 2012. They came out and said they thought it was doing more harm than good. The mortality rate, though, has at least been declining with prostate cancer in red. You can see here it's declined significantly over the last 20 or 40 years almost. And a PSA screening is thought to account for 45 to 70% of the benefits. So the screening has done some good. In both Black patients and white patients, the incidence of prostate took off with the PSA and has been slowly declining ever since. And by different racial groups, you can see it's well known that Black men have a much higher likelihood of prostate cancer than white men. And it's been consistently higher. So again, if you look at this statistic, white male, 2.3% chance of dying of cancer, 12% chance of getting it, whereas an African-American man, 3.8% chance of dying it, much higher, and 16.7% chance of getting it, also takes off a little bit earlier. So screening an African-American man a little earlier is recommended. So if you look at the numbers again, a Black man has a 76% higher likelihood of being diagnosed and twice as high likelihood of dying of the disease. So how much of that is due to genetics or biology? How much of that is social political? Obviously, in 2021, there's a lot of interest in health equity. There was a recent study that looked like prostate cancer was more due to social factors and access to care than genetics. This was in 2019 in JAMA, but a more recent study on genetics, a meta-analysis of all the genetics, found that there are now 269 known risk factors for prostate cancer. And the genetic risk score for African Americans is twice as high as for white men, and East Asian men, it's much lower. So there's a strong genetic component, and there's probably also social, political, economic component. If you look at all diseases by race, African Americans have a higher rate of dying of cancer than white people, but their overall death rate from all causes is higher. And if you compare this, the likelihood of dying of cancer is not much higher, in fact, not quite as higher than overall death rate. So it's not clear exactly how to sort this out. Again, in fact, in general, the odds of getting cancer in a Black patient is lower than a white patient. So the death rate is higher. Now that would look like access to care, but it might mean that cancers are more lethal. And some cancers make no sense. The breast cancer is a little lower in Black patients. Leukemia is a lot lower in Black patients. Myeloma is a lot higher in Black patients. Ovary cancer is lower. Thyroid and bladder cancer are both much lower in Black patients than white patients. So clearly it's not social political. And then the most recent data on life expectancy that was affected by COVID, the Latino group suffered the most. Their life expectancy fell from 81 to 78, but they still have a longer life expectancy than white people. So there's a so-called Latino paradox. Despite low socioeconomic issues, they have a longer life expectancy. So clearly there's a genetic component of some sort. So can you prevent this cancer? Well, it's clearly related to testosterone and some role for genetics. According to the NCI, the main risk factors are age, hormones, race, diet, and vitamins. There were several studies that tried to lower testosterone with drugs like Proscar, Propecia, Avodart. There wasn't enough benefit to recommend those. And the studies on vitamin supplements have basically not worked out. In fact, one of the vitamin E trials, cancer of the prostate went up. As far as genetics, that's the NCCN now added genetics or germline testing to their way to evaluate prostate cancer. And so if the patient has a family history, you should consider doing a germline or genetic testing. If the patient has high risk, meaning a high Gleason or high stage, you should recommend genetic testing. So again, high risk cancers, Jewish ancestry or strong family history, which means a first degree relative, father or brother or son having prostate cancer, particularly if they got cancer when they were less than 60 or it was a more lethal cancer, they died of it. If you have these kind of high risk features, the odds of finding an abnormal genetic test is 6%. And if you have people who already have metastatic prostate, the odds they have an abnormal gene is as high as 11.8%. And the number of genes, as noted, keeps growing. So is it worth getting my PSA level tested? So this is from the NCC, and prostate cancer represents a spectrum of disease that ranges from non-aggressive, slow-growing, that may not require treatment, all the way to aggressive, fast-growing disease that does require treatment. So we need a strategy that maximizes detection of cases that are effectively treatable and if left undetected, represent a risk to the patient. So it's the proper use of these tests is important. So if we go back to this PSA test, is it too sensitive, not too sensitive? As noted, the US Preventative Task Force came out in 2012 and recommended against getting it. So what is the PSA? Well, prostate-specific antigen. It's a chemical, a glycoprotein made by the prostate cells to lyse the clotted ejaculate to increase sperm mobility. So it's a normal, necessary component. And it's only when it gets over 10 that the risk of cancer gets particularly high. And as noted, in 2012, the US Preventative Task Force said, don't do it. Though in 2018, they changed their mind and said, all right, you can do PSAs or talk about it, but only in a certain age group, 55 to 69, and you could certainly quibble, is that the right age group? So the US Preventative Task Force, you can download their app, it's very useful. If you go to their recommendations, the ones that came out in 2018, they basically said, C, consider going ahead and testing men in 55 to 69, but only after you have this long conversation about the pros and cons. If the man is 70 or older, don't do it. So in simple words, talk about it or discuss it. In this age group, don't do it if the man is 70 or older, even though I just pointed out most cancers are not diagnosed until the man's 70 or older. And they quote their evidence, or where did they come up with this evidence now in favor of limited testing? They said, well, there's 63 studies, almost 2 million people. They mentioned that the studies that showed no benefit, not associated with reduced risk, were badly flawed studies. There was contamination in the control group, or people didn't follow the study, low adherence to even getting the test done. Now, why they even included studies that they know were no good makes no sense to me. The studies that show that were done properly in Europe showed a significantly reduced prostate mortality. The relative risk here is 0.79, so 21% lower risk of dying of prostate cancer if you do proper screening. And so it does reduce the mortality. But there are issues related to side effects and treatment, et cetera, et cetera. So what happens if the government decides not to do testing? In the UK, they test for breast cancer. They do not test for prostate cancer. This was a recent publication from the UK. They said, surprise, surprise, the number of prostate deaths in the UK has now overtaken the number of breast cancer because we screen for breast cancer, and that's saving lives. But then they said last year, prostate cancer is now more common than any other cancer in the UK, not so in the US. They said, well, we don't do PSA testing because we don't think it's reliable. We don't even do digital rectal exam because we don't think that's reliable. So a strategy of not even screening probably doesn't make sense. And one final piece of advice when you're thinking about screening or treating is life expectancy. Most of the guidelines probably sensibly say you need a 10-year life expectancy to make all this worthwhile. So the average 75-year-old man has a 10-year life expectancy. That's average health. If you're healthier than most, the average 75-year-old actually lives 50% longer, 15 years. And those who have particularly poor health live 50% shorter, 5 years. And then the most recent numbers from Social Security, the 10-year life expectancy for a man is hit when you're 77 years old. And again, you could add 50% to that if you are particularly healthy, or drop 50%. And so what are the normal PSA scores? Normally they should be in these low numbers, perhaps better than that. Is testing even more sensitively. So if the PSA gets between 4 and 10, the odds of cancer starts to get higher. If the PSA is greater than 10, then the odds of cancer is significantly high, and most people would recommend biopsy. It may be more interesting to look at these lower numbers. When a man is 40 to 49, the normal PSA for him is not up to 0 to 2 or 4. It should be only 0.7. So if it's higher than that, you might be concerned. If a man is in his 50s, it shouldn't be any higher than 0.9. If it moves up more than 0.75 in 1 year, that's concerning. If you make it to 60 and your PSA is less than 1, the odds of you ever having serious cancer is very low. If you make it to 75 and your PSA is 3 or lower, the odds of ever having serious cancer is also very low. And it's worth knowing if your patient is on drugs like Avodart, Proscar, Flomax, saw palmetto, they may lower the PSA by as much as 50%. So if a man has a PSA that says, oh, it's not that bad, it's only 4, but he admits he's on saw palmetto, you should really not say it's 4, it would be 8, and that may be high enough to get your attention. So what does the NCCN guidelines say? Well, they say they should screen people this age group, 45 to 75, for average risk patients. And if you're African American or it runs in your family, even start at the age of 40. And then they give you the numbers when they would start to pay attention. If it's still less than 1, repeat it at long intervals, 1 to 3, maybe every year or 2. If it's over 3, then you might consider doing something. So what would you do? Well, the first thing you would do is repeat the test, because 25% of the time it's a false positive, which means there's nothing wrong with you. And then consider doing a digital rectal if it wasn't done before. And then they say, before you rush to do a biopsy, consider getting an MRI or some biomarkers, the MRI or the biomarkers. So again, basically they're saying a PSA alone is probably not good enough to decide on a biopsy unless it's really high, greater than 10 or 15. So step 1, consider after repeating it to get an MRI to determine if it looks like cancer and where to even do the biopsy, and then do these biomarkers. So an MRI of somebody with benign prostatic hypertrophy typically looks like this large area here called the central zone, often looks awful and dominates the picture, but cancer typically shows up way in the back here in this very small peripheral zone. So this is actually what MRI of an early prostate typically looks like. There's this huge central zone here which dominates the picture. The peripheral zone is this small area around the back, and the cancer was that little vague shadow. So MRIs are difficult to read, and you need an expert on the MRI. And then finally, the biomarker. If you don't trust the PSA, well, what's a better test after you have a PSA? And you should do biomarkers. And I would only do the ones that are recommended by the NCCN. So consider the free PSA. It's been around the longest. So if you had a normal PSA, say your score was between 4 and 10, what's the odds of cancer? 25 to 30%. Well, that may be too low for you to want to go through a biopsy, though it may be too high for you to ignore. So instead you ask your doctor, I want a free PSA. And so if the score happened to come in that range, the probability of cancer is extremely high, and you probably would agree to a biopsy. If the free PSA score came out like that, it turns out that has a very low risk of cancer, and you would politely decline a biopsy. That makes sense. Another one that's popular is the 4K score. It's also a blood test. It tests for some other fancy PSA type blood test. There's another urine test called Select MDX. It measures in the urine for some genetic testing and has very good probability of accuracy. So what they're saying is if you have a low Select MDX, they can say with accuracy, 95% sure you don't have a Gleason 7, which is serious, or the dangerous Gleason 8. They can say you have a 99% certainty you don't have a Gleason 8. So depending on the man's age, he may decide after the Select MDX that he can wait a while before he decides to go with a biopsy. And another one that's popular, ExoDX. It uses something called exomes in the urine, and it uses the exomes to look for, again, some of these new genetic factors that have been identified. If you've never heard an exosome is a vesicle or a little sac of fluid that's secreted from the body, and you can measure that for these abnormal genes. So putting it all together, you would say, number one, because prostate is so common and so indolent, you need a strategy to avoid overdiagnosis and overtreatment. Number two, checking a PSA at a baseline, maybe in your 40s or 50s, may give you some sense of long-term risk. If you make it into your 60s and your PSA is less than 1, your risk is very low. That's good news. If you make it to 75 and your PSA is 3 or lower, that's very good news. Depending on your perceived risk and life expectancy should guide how often you even consider checking the PSA or whether you even bother. And then if the PSA is elevated, special tests should be considered before proceeding to a biopsy. If the biopsy shows cancer, there are other tests that determine the best treatment, and I will discuss that in a future video.